All right, folks, here's part 5 and our last module here in antipsychotics or dopamine serotonin blockers, which you notice has changed from dopamine blockers because these are the second generation antipsychotics, which to be a second generation antipsychotic, you have D2 blockade or partial blockade and also serotonin 2A activity, in addition to other receptor activity, which we'll go over as we discuss these prototypical drugs. So again, I've grouped these by potency. So we have our low potency second generation dopamine blockers or antipsychotics, clozapine and quetiapine, which I'll talk about in more detail. Our medium potency, olanzapine and aripiprazole, and some others that are listed there. And then our prototypical high potency second generation antipsychotic is going to be risperidone. So again, similar kind of factor of 10 dosing that happens with these drugs, just as a ballpark idea of potency. So our classic second generation antipsychotic, or the first of the atypicals, was called clozapine. And this drug has been around surprisingly for a long time, since 1989. And so it was the first. The second was olanzapine, which came along in 1996. So as you can see, this is a low potency drug. Doses are typically in the sort of 200 to 400 milligram range. You're not going to start at that. You're going to start at low doses and work up for reasons which will become evident in a moment. Now, what's interesting about clozapine is that it's a very effective antipsychotic, but curiously, it has fairly low occupancy of D2 receptors, around 40%. Now, the good news about that is you're very rarely going to have those kind of movement extrapyramidal symptoms that you get with the greater blockade of D2. But this is one of the things that's kind of mysterious about clozapine is, given its fairly weak effects on D2, why it's so darn effective for schizophrenia. And that may be because there's a synergistic effect of all these different receptors. It's not totally clear, but it's an interesting phenomenon with clozapine. Now we can see with clozapine high activity on the histamine receptor. So H1, a lot of blockade there, which is going to result in sedation and weight gain, which is sort of notorious for clozapine, both of those. It also has a lot of activity at the muscarinic 1 acetylcholine receptor. This is going to lead to all those anticholinergic side effects of blurry vision, dry mouth, urinary retention. But it also has that benefit of when you have something that has a lot of anticholinergic effects, you have less extrapyramidal symptoms because, again, it's sort of like you've got cogentin built into this. So typically, this doesn't require additional anticholinergic medications to be tolerable from an EPS standpoint. It does have a lot of activity on that alpha-1 noradrenergic receptor, which again is going to cause those predictable symptoms of sedation, orthostasis, and dizziness, which again inhibit tolerability. And despite all this is still considered the most effective or gold standard second generation antipsychotic. One of the reasons why you don't see as much clozapine used as you might imagine, given its effectiveness, is because of this blood dyscrasia that can happen. Blood dyscrasia, that would be a great name for a band. Agranulocytosis, so loss of a certain type of white blood cell, can happen in about 1% of people. And this can be life-threatening. This can be lethal. In fact, when clozapine first came out, people died from this until they figured out what was going on. So what the FDA required is something called a REMS program, which stands for Risk Evaluation and Mitigation System, I believe. And they said, okay, if you're going to prescribe Clozaril, first of all, you have to be enrolled with the REMS program as a provider, and you have to have a pharmacy and a lab that work together. So this makes doing this med a little tricky, but very effective if you can do this and if you need it for your patient. So what it requires is weekly blood draws, so a CBC with diff every week for 6 months. And typically the way it works is they will only prescribe the med if you've had the blood draw. So if you haven't done the blood draw, they won't prescribe the med. After 6 months, you can go to every 2 weeks and then monthly from there on out. So you got to do it. So you really have to do this with patients that can follow this routine. And that is tricky, as you might imagine, with patients with schizophrenia, because cognitive disorganization is part of the disease. So my experience with clozapine is that it works best with patients who are very well supported, either by an institution, like they're staying in a long-standing long care board and care facility, or they're supported by their parents, their family. If somebody can make sure they get to the lab and make sure they pick up their meds, then this can be successful. Somebody who has fewer of those resources, that's going to be more difficult. There are other life-threatening side effects that can occur with clozapine, such as myocarditis, paralytic ileus, which can lead to sepsis, and seizures. So again, very effective med, but can be tricky to use. This also has a lot of the same metabolic risks that we see with many of the early atypicals. So hyperlipidemia and potential for inducing weight gain and diabetes. A quirky common side effect of clozapine is sialuria, so drooling, and that can often be managed by using, you get ophthalmologic, I can never say that word, atropine eye drops, and you use them off-label, just a drop or two under the tongue, because the drooling is usually worse at night. And that will, that's an anticholinergic med. It's only absorbed around the salivary glands and tends to dry those up so that the person doesn't wake up with their pillow soaking wet. Clozapine is also is known for reducing suicide in patients with schizophrenia. And interestingly, despite the fact that we prescribe a lot of meds to a lot of people with suicidal ideation, such as antidepressants, they actually don't statistically reduce suicide rates. Clozapine is an exception, as is lithium and probably ketamine as well. So usually this is a drug that is referred for refractory schizophrenia. So people have tried 3 or 4 different medications and it has not worked. We think about clozapine. The good thing about this particular medication is that it's quite cheap, although the blood monitoring is an added cost. So let's look at another low potency second generation antipsychotic, which is quetiapine. This came out in 1997. So you see from the potency range, doses, it has quite a wide dosing range. 50 to 800 milligrams is not uncommon. Also, interestingly, has that weak D2 blockade, around 40%, similar to Clozaril, and has moderate serotonin 2A blockade. So that's what makes it atypical, but it really doesn't stick to that D2 receptor for very long. It does that bus stop thing where it just stops by, sits down for a few minutes, and then moves on down the line. So it's not a real potent D2 blocking medication. And you'll see, if you look carefully there, it says norquetiapine, because it's really the active metabolite that has more activity at the receptors. Significant antihistaminic effects. So again, the predictable side effects of weight gain and sedation that come from blocking the H1 receptor. Also blocks that alpha-1 norepinephrine receptor, leading to, again, the predictable dizziness, sedation, and orthostasis. Now, quetiapine is interesting because it's used a lot off-label in psychiatry. So small doses, which are largely have an antihistaminic effect, can be used for sleep, sometimes used for anxiety, does not have an antipsychotic effect at those low doses. The medium doses are an FDA-approved treatment for bipolar depression and can also be used in bipolar mania. And so that has that sort of, that mama bear, as the illustration here from Stahl says. And then higher doses, as high up as 800 milligrams a day, can be used for psychosis or for very severe acute mania. So typically, a rule of thumb is that for atypical antipsychotics, if you're using it in bipolar disorder, particularly if it's a drug that is approved for depression in bipolar disorder, you're usually looking at about half the doses you would use for psychosis. Norquetiapine, being that active metabolite, also works on the norepinephrine transporter, so a little bit like bupropion, if you will, and also serotonin 1A and 2C, which agonism on those at those sites tends to result in antidepressant effects. Sorry, antagonism at 2C and agonism at 1A. But this weight gain, metabolic syndrome, and sedation can be limiting. Quetiapine is now generic and is quite inexpensive, which is great because when it first came out, it was about $10,000 to $11,000 per year. And now it's a fraction of that. Let's look at another medium potency antipsychotic. So this is aripiprazole, came out around 2002. You'll see the doses are somewhere around 5 to 30 milligrams. Typically, you want to start this relatively small, 2.5 to 5 milligrams. If you go higher than that, you're going to cause akathisia right out of the gate. So I would suggest starting this dose fairly small. It is an interesting drug in that it is a partial agonist at the dopamine receptor, the D2 and D3 receptor, which might have you kind of scratching your head and thinking, well, wait a second, if you activate the D2 receptor, wouldn't that actually contribute to psychosis, particularly in the mesolimbic tract? And you would think you'd be right. But what this is thought to do is actually kind of stabilize the activity of that receptor. So it's a little bit of an odd bird. It also, like all atypical antipsychotics, has activity at blocking the serotonin 2A receptor. Now that D2 activity does result in akathisia, as I mentioned. So want to dose this small in order to make it successful. And when this first came out in 2002, all the drugs that came up before that, with maybe the exception of ziprasidone or Geodon, all had this problem of causing weight gain. Olanzapine, risperidone, Zyprexa, which is olanzapine, or quetiapine, which is Seroquel. Those all were very popular, but they were all causing a lot of weight gain. And then aripiprazole comes onto the market and says, hey, I don't cause as much weight gain. And people got really excited about it. And as time has gone on, it's turned out that this is not totally weight neutral, which shouldn't be terribly surprising when we look, and we do see that it does have some antihistaminic effects, which is going to result in some sedation and some weight gain. So this is indicated for use in schizophrenia, in bipolar mania, and increasingly you're seeing this used added to SSRIs or SNRIs as a way of augmenting an antidepressant, which can be a reasonable strategy. I would say that there are other strategies that may be more successful, such as lithium augmentation, which I'll talk about in the treatment-resistant depression section. But there is some utility in using this. You want to be thoughtful about it because all antipsychotics, all dopamine blocking drugs can lead to movement disorders such as tardive dyskinesia. So you need to put that into your calculus when you're thinking about if you want to use this medication in a patient who does not have psychosis, who has unipolar depression. So some of the antidepressant effects that make it useful in antidepressant augmentation may be the result of serotonin 1A agonism, serotonin 2C antagonism, and activity on the serotonin transporter, so similar to an SSRI. And interestingly, because of that odd activity that it has on dopamine receptors, this is sometimes used to actually reverse hyperprolactinemia caused by other dopamine blocking drugs. And it is available in a long-acting injectable, which we'll talk about in the next module where we talk about LAIs in general. And now again, since this has gone generic, it's gone from about $12,000 a year to a fraction of that. So it definitely is more affordable. Some other medium potency second generation antipsychotics would be olanzapine, which came out, as I mentioned earlier, in 1996, really trying to make a safer clozapine that didn't cause agranulocytosis. A very sedating drug, very likely to cause weight gain and metabolic disturbance, also very effective. So definitely has a place in psychiatry, particularly in short-term kind of emergency situations. You'll see this used a lot in inpatient settings and in psych emergency. Interestingly, olanzapine is cleared through the cytochrome P450-1A2 enzyme, which is induced by smoking. So if somebody is a smoker taking olanzapine and then goes into a hospital, can't smoke, they're actually going to see their elevation of their olanzapine levels in their bloodstream. Now, the problem is they may get stable in a non-smoking hospital, then go home, go back to smoking, and that CYP1A2 induction is going to cause that drug level to lower. So you could be setting somebody up for potential relapse if you send them home and you know that they're going to smoke. So you want to keep that in mind when you're dosing this. And again, now that it's gone generic, it's quite cheap. Ziprasidone was really the one exception to the metabolic disturbance of these older second generation antipsychotics. It had got a bad rep for a little while for potentially increasing QTC. Turns out that was probably overstated. This is kind of one of my back pocket meds for when I want to have a second generation antipsychotic that's cheap and generic and not likely to cause weight gain. I like ziprasidone a lot for that reason. You do need to dose it with some food in order to get full absorption. Lorazepam or Latuda, or as one of my patients' mothers called it, Laduda, is a a newer medication, about 10 years old now, also more weight neutral, sort of that medium potency, not likely to cause as much weight gain. And where it's gotten a lot of traction is in the treatment of bipolar depression. So we'll cover this a little bit in the mood stabilizer lecture. And until 2023, it remains generic. So it's running about $10,000 or $11,000 per year. Brexpiprazole, which is Rexulti, came out about 5 years ago. This does have an FDA approval for schizophrenia, but largely has been marketed as an augmentation agent for antidepressants, which shouldn't be surprising because it's essentially a cousin of aripiprazole. Also a very expensive medication until it goes generic, and that probably won't be for another, I would guess, probably 5 to 8 years. Lumateperone, I can't pronounce it yet. It's so new. It just came out a couple of years ago. This is a medication that has indication for schizophrenia and also recently was FDA approved for bipolar depression, which is a great thing because we have a limited arsenal in the treatment of bipolar depression. So it's always nice to have another drug available. This is an interesting drug because it has fairly modest D2 affinity. Doesn't have a lot of activity on histamine or the muscarinic receptors, so it doesn't have as many of those side effects. It has an interesting mechanism of action because it does the standard D2 and serotonin 2A blockade, but it also works on something called the dopamine autoreceptor. So if you think back to when we learned about autoreceptors in the first couple of lectures, some meds, an autoreceptor is like a thermostat. So it essentially, when enough of the neurotransmitter is released into the synapse, some of that floats back up and hits the autoreceptor, which essentially tells the presynaptic or releasing neuron that, okay, you can turn off the signal right now. You can turn off release because enough is in the synapse. So if you block that, or if you activate it, you kind of trick the presynaptic neuron into slowing down how much dopamine it's releasing, which is advantageous when we're treating psychosis where there may be over release of dopamine. It appears to be a pretty weight neutral medication, but again, very expensive and will not be generic for many, many years. So let's finally turn our attention to a high potency second generation antipsychotic. In this case, the prototype is risperidone, which also came out around 2002. This is a high potency medication. As you can see, doses are usually somewhere around 1 to 6 milligrams. And it has that potent antagonism against D2 and also serotonin 2A. It does have significant antihistaminic effects. So it does block that H1 receptor, which causes the predictable sedation and weight gain, and also blocks the alpha-1 receptor of norepinephrine, which causes that dizziness and orthostasis and also contributes to sedation. Now, this is an interesting medication because its potency tends to cause blockade in the tuberoinfundibular tract. Now, if you remember back to what the tuberoinfundibular tract does, is it regulates the release of prolactin. So of the second generation dopamine blocking agents, this medication is the most likely to cause hyperprolactinemia, which is something I've definitely seen in clinical care, and I've seen gynecomastia and the induction of breast milk. So that can definitely happen with this medication. So if you have somebody on risperidone for the long term, it's a good idea to check those prolactin levels. And prolactin will also, as I mentioned earlier, decrease bone density, and it can also be a contributor to low libido. So risperidone was created by Janssen. It's essentially a derivative of haloperidol. So they were looking to see if they could adjust the haloperidol model, which makes sense given its potency is similar to that of haloperidol. But it also comes with some of the same problems that haloperidol does, such as EPS and the hyperprolactinemia. It's not without metabolic risks, such as weight gain. Now, paliperidone, which you may notice has a very similar kind of sound, makes sense because it is actually the active metabolite of risperidone, and kind of like Pristiq is the active metabolite of Effexor, paliperidone is the active metabolite of risperidone, and it is sold as a drug called Invega, which is available as a separate it's a different drug, but it's essentially the active metabolite of risperidone. And both risperidone and paliperidone are available as long-acting injectables, which will be talked about in the next lecture. And risperidone now is generic. So other high potency second generation antipsychotics, paliperidone, as I mentioned there, which has some utility in that it's not metabolized by the liver. So it pretty much is excreted unchanged, which means you have fewer problems with drug-drug interactions, but it has the same problems of sedation and metabolic disturbance that its parent drug, risperidone, has. And you also need to monitor for hyperprolactinemia with that drug as well. And Invega is now generic, so it does make it cheaper. Iloperidone is Fanapt. This is an interesting drug. I don't see it used a whole lot, to be totally honest, but it does have very potent alpha-1 antagonism, which means that you're going to run into sedation and orthostasis. But interestingly, it seems to be more metabolically benign, so not a lot of weight gain. This is going to remain generic until 2027, so it's going to be quite expensive to use. Acenapine recently went generic. This is also known as Saffris. This is a curious drug in that it only comes in a sublingual formulation. So that it has to be put under the tongue and dissolved. Pretty sedating, has some metabolic risk, but has the advantage of being generic now. And cariprazine or Vraylar is about 5 years old now, and so this is an interesting drug because it has activity on dopamine 3 receptors as an antagonist, and also is an agonist at serotonin 1A, which, as you recall, confers some antidepressant effects. So this is why this probably got approval for bipolar depression, which again is useful to have another drug in the arsenal, and is also approved for schizophrenia. It's well known for causing akathisia, and so you want to titrate this really slowly, usually every other day or every other day, and that's because of the long half-life of the medication. It is more metabolically benign than some of the older second-generation antipsychotics, but it is quite expensive and won't go generic until 2029. I do want to bring your attention to one sort of odd duck in the arsenal here of second generation antipsychotics, and this is pimavanserin, which is also called Nuplazid. Now, this is an interesting drug because it is specifically FDA approved for psychosis in Parkinson's disease. Now, why would we need a specific drug for Parkinson's disease? Well, let's think about this for a minute. Dopamine, as we know, is what is deficient in the Niagara striatal tract in Parkinson's disease. So these are folks that have that degradation of the substantia nigra. And so if we go ahead and block dopamine with a typical or a standard atypical antipsychotic, we're going to be blocking those D2 receptors, which is probably going to make their Parkinson's worse. So this is the only second generation antipsychotic that has no D2 activity, which is really quite unusual, but it's very potent blocker of serotonin 2A, and also does this inverse agonist thing, which is a little hard to understand, on serotonin 2C, which might actually release dopamine in some areas that helps with the depression and negative symptoms of psychosis, but doesn't worsen the motoric symptoms of Parkinson's. So very interesting drug, still generic, still branded, not generic, and expensive. So these are some things that you may see in the years ahead. The trace amine receptor agonists. This is an interesting new area, as I understand it, in pharmacology, that is looking at how are monoamines such as dopamine and serotonin regulated within the cell. And these particular drugs may also work on those dopamine autoreceptors to sort of slow down the outflow of dopamine into the synapse, causing some antipsychotic effects. There is increased interest in the dopamine 3 antagonists. Cariprazine or Vraylar is an example of those. So there's others like it in the works. Cholinergic agents for improving cognition, sorry, the text is cut off there, are in clinical trials. And then cannabidiol, which is what this chart here is for. So this is the non-intoxicating part of the cannabis plant. So CBD, as you're probably well familiar with it, turns out in high enough doses has antipsychotic effects. and may balance out some of the psychotomimetic or psychosis creating effects of THC. So this is an example of a study that was done against amisulpride, which is a drug that is not available in the US, but is well used in the rest of the world. It's a early atypical antipsychotic, showing that it was really equivalent in its antipsychotic effects to amisulpride. So that's a sort of a tantalizing finding there. Now, the caveat on that is that the dose for CBD is often way higher than anyone is going to be able to easily obtain from a dispensary. It's often in the sort of 300 to 1,000 milligrams of CBD orally per day, which is well beyond the reach of most people going to a dispensary. So this is an interesting finding. So things that you may see in your future career. And with that, I want to thank you for your attention through this whole module. And I hope that this was interesting and made sense. All right. Thanks. Bye now.